Hi, Doc.
All right. So remember, it's no pressure, but this is just an attempt to prepare you for the exam. So, and if you don't know something, that's fine. But this is a time to not know. Okay. So you go into the exam in the oral exam, and you see the urology station. And in the urology station, you're gonna see things like X-rays, CT images on a computer. You're gonna see instruments on the table like catheters, stents, and so the discussion can come around those topics, okay? So say you meet up on an examiner who shows you a two-way Foley catheter, and they ask you to tell me, what is this? Tell me how you're going to respond.
I'd respond saying it's a in and out catheter to help
Two-way Foley catheter, in a two-way.
two-way.
Yeah, so in and out catheter is not a two-way Foley catheter, is it, right?
No.
No, right. So you see a two-way Foley catheter, and it usually we expect you to be able to describe it, right? So say to me, this is a two-way Foley catheter, and describe the components of the catheter. Can go ahead.
Okay, so this is a two-way Foley catheter. It has a pilot to inflate the balloon so that I can retain inside the bladder. It's made out of oh boy, I can't remember what it's made out of. But yes, it's used to help relieve the. It would be a self-contained.
What you just did a while ago, don't do it. Nobody asked you what it was made up of.
Yes,
you brought it up. So you brought it up and then you left it hanging. All right. So
yeah.
The examiner would not have asked that, but because you went and brought it up and you left it hanging, somebody may pounce on you and say, tell me about what it is made up of and all of that. So just don't open any doors you don't want opened. All right. Unless somebody asks you what it is made up of, you can mention that. But you don't have to. But just for your own edification, most catheters are made up of latex. You have plain latex catheters with a silicone outer covering. So most of the catheters that you see are yellow or orange in color. They are latex catheters. But there are catheters that are made up of silicone, and they're translucent and clear. Okay? It has a different property from the latex catheter. So if you look at a catheter, some of the parts of it you want to talk about is that it has an atraumatic tip, which is useful for insertion. And it also at the base, it has two ports. One port is for the inflation of fluid for the balloon, and you can know the volume that should go in the balloon based on the notation at the base of the catheter. It's not rocket science, it's not 10 cc's for all catheters. It's written there because some catheters need 10 cc's, some need 30, some need 5. So you have to know which ones to put in, right? And these are basic questions you can get asked in the exam. Why do you think you would have a catheter with a port, a balloon size accommodating 30 cc's? Do you know? Does anybody know? I see Paige's hand up. You can go ahead and ask a question, Paige.
Yes, Doc. I heard that we don't usually inflate it to the maximum bulb size because it can cause like the patient to have a reflex in which they want to urinate, and because like the pressure on it.
And this was you were expertly advised by a urologist?
Not a urologist, but
Okay.
this was Jen.
All right. So who you think you're gonna listen to, the urologist or the general surgeon?
Okay, Doc, I'll listen to the urologist.
All right. So catheters have various balloon sizes, and you put in what is recommended. Now, yes, when you have a large balloon in the catheter, it can irritate the trigone and lead to bladder spasm. But you also don't want the catheter to fall out, do you? Because you don't want to have to put it back in again. So if the catheter balloon size says 5 cc's, you put 5 in. If it says 10 cc's, I'm not going to put 5 in, I'm going to put 10. But some can hold even up to 30 cc's. And these are like in patients who have just had a transurethral resection of the prostate, where they have a large, wide, open prostatic fossa, and we use those catheters with the large balloon to create some amount of tamponade and hemostasis. So it's very, very useful there. So you wouldn't put a 30 cc balloon catheter in a routine person, but if it's post-transurethral resection of the prostate, you can put that in. All right. Catheters have various sizes, and the sizes that are used are appropriate to the patient gender. So what size catheter do we generally use in women? Amelia?
Hey, Doc. Let's go with 20.
No, Amelia, and it's not it's not a trick question, and it's not a guessing game. So exam technique is very important. So you're not gonna say let's go with this. Is not a game show. It's medicine. It's what you have learned. And if you do that in an exam, you're going to fail. I'm sorry, I just have to be blunt. So it's not let's go with, it's what is correct or incorrect. So when you say it like that, the assumption from the examiner is that you have not been around, you have not been on the wards. So I know COVID was a thing, but COVID kind of cooled down for the past year. And even so, you read books, so you should know what the standard catheter size is. So that come July 1st, when you start working with us as an intern, then you should know which catheter to put in a woman. So can anyone tell me the appropriate catheter size for a female?
I think
14 to 15 French.
So there's no such thing as a 15 French catheter.
14
Again,
French.
it's telling what you guys have been exposed to, all right? Catheters are only in even numbers. So it is a 14 French. So you're close. Okay? What size do we put in men? 16 to 18, correct, Ashley. All right, so for women, it tends to be the 14 French that is inserted, and for men, it is the 16 French. Sometimes we may put in an 18 French there also. All right, okay. So you have two ports. One port to inflate the balloon, and we've spoken about the nuances of the balloon. It's not a one size fits all. And we also have the port for the for drainage. So what is the difference between the two-way and three-way catheter, Anik? Do you know? Just let me know if you're hearing me, because I can't tell when I don't hear anyone speaking.
We're hearing you, Doc.
You're hearing me. All right. So what's the difference between the two-way and the three-way Foley catheter?
The three-way Foley catheter, Doc, it allows for irrigation of the bladder, especially when you have hematuria.
And why would you? Excellent. Why would you want to irrigate the bladder?
Just like, so when you have hematuria, you're going to have stasis, and it's going to cause coagulation, so you can get obstruction. So you're going to need to irrigate the bladder in cases of hematuria, so that the urine will flow free.
All right. So hematuria and hematuria secondary to what though? Like in what situation do you see us routinely putting in these three-way catheters and irrigating the bladder?
So in a situation where there's blunt trauma to the bladder.
Blunt trauma? You think with blunt trauma would want to irrigate the bladder? What if you were to irrigate the bladder in someone who's had blunt trauma? Don't you think that urine would extravasate? That fluid, that irrigation would extravasate out, potentially? The answer is no, but there's a more common scenario in which you see us irrigating the bladder post-operatively. What do you think it is?
When you have instrumentation?
No, with instrumentation, you really shouldn't have that level of hematuria, so we shouldn't be irrigating that. So what scenario?
Doc, when you have shockwave lithotripsy.
No, the answer is not. It's no, that we don't irrigate the bladder after shockwave lithotripsy, thankfully not. But I just heard the answer coming out after TURP, and that is correct. So if someone has a transurethral resection of the prostate, or if someone has a transurethral resection of a bladder tumor, which are elective cases that we perform, then yes, you want to irrigate the bladder in those situations. Okay? All right. We don't irrigate the bladder after shockwave lithotripsy, and we certainly don't irrigate the bladder after trauma, because if there is a potential for a rent or tear in the bladder to exist, all you're simply doing is allowing the irrigant to go out into the pelvis, and that's not cool, right? All right. So what about this in and out catheter that I heard Amelia mention? What's the purpose of that catheter?
That would it be
Single
for,
port catheter. What is the purpose of the single port catheter?
would it be for intermittent catheterization?
Excellent, excellent. So, who is this? Dejane?
Yes, doc.
Excellent, right? So intermittent, you use it for intermittent catheterization. And which patients do you have to perform intermittent catheterization in?
So I know they can use it if you are doing a catheter specimen for checking for urinary tract infection.
Yeah.
Also, if you have a neurogenic bladder.
Yes. If the person cannot void, because you don't want to instrument people, but if the person cannot void on their own and you need a catheter specimen of urine, yeah, but what is probably the more common? I see Ashley saying gynae or obstetric patients. I would say obstetrics. So patients who are in labor and their bladder may be full, sometimes the gynecologists or obstetricians, may put an in and out catheter in just to empty the bladder, and that will aid in descent of the fetus's head, right? But what if you were to have any one of you been down to Mona rehab?
Well, neurogenic bladder?
John Bolin rehab? Okay. Correct. If the patient has a neurogenic bladder, so someone who has a spinal cord injury, who is not able to void on their own, rather than having an indwelling catheter long term, which is associated with risk, you can teach the patient how to do clean intermittent self-catheterization, and that's a much easier thing to do. It reduces the risk of infection, quality of life is better, and overall it's better for the patient. All right? So you must know the different types of catheters, and believe it or not, these are easy questions to ask in the exam. All right, if you come to the table and that's all that is asked of you, then the examiner is being very generous. Okay, so we really shouldn't stumble on these things. The in and out catheter, which is used in obstetrics or for the neurogenic bladder, the two-way Foley catheter, which is your standard bread and butter catheter, 14 French for women, 16, 18 for men, your three-way Foley catheter that is used for irrigation. All right, so have you ever heard of the Coude tip catheter?
Is that the catheter that it has like a curved tip, and they use it in patients with
tip is
BPH?
Curved, right? So that's excellent, Dejane. So that catheter is used for the patient who has difficult catheterization. So it's not the first catheter you would reach for a patient, but for the patient who has difficult catheterization and you believe it is due to an enlarged prostate, you can use this catheter because the tip is curved, and that allows you to go over that mound of that large so-called median lobe that is right at the bladder neck. So easier to insert. So sometimes you may get asked a question, say, let me present a scenario to you. You have a 65-year-old male who presents to the emergency room who is not able to pass urine, hasn't been able to pass urine for the past 6 hours, and he's having low abdominal pain. When you examine the patient, you notice a tender globular mass arising from the pelvis, and you happen to do a rectal exam quickly, and the patient has an enlarged prostate. What is your diagnosis at the time? Diagnosis, anyone?
Doc, urinary retention?
Urinary retention, right? So I see Ashley says bladder outlet obstruction, and I would like to say it's urinary retention. We have to be specific. But if we say urinary retention, what type of urinary retention is that? Acute, exactly. All right. So acute urinary retention is the inability to void associated with pain. All right. So inability to void associated with pain. If the patient is unable to void, but there is no pain, we generally call that chronic urinary retention. Bladder outlet obstruction is maybe the cause of the urinary retention, but the patient's presentation at the time is that of urinary retention. Okay, so we know that there are certain features that may be seen in people with chronic urinary retention, and these include things like a large retention volume. So when the person is catheterized after the diagnosis of urinary retention is made, you have a retention volume, that is the volume of urine that is emptied from the bladder, a retention volume of on average a liter or greater, which you know is almost twice the maximum bladder capacity. The patient may also be at risk for renal impairment, hydronephrosis, and hydroureter. Okay? It doesn't mean that they will have those things, but they're at risk for it because of the nature of the presentation of chronic urinary retention. They likely have been having poor emptying for a long time, so it results in long-standing hydronephrosis, hydroureter that they're not aware of, and even renal impairment. And so they tend to present much later than those with acute retention where they have pain. Now, acute and chronic retention is a little different because the patient has a large retention volume greater than a liter, but they may also have pain due to other reasons, maybe pain from an infection, pain from a stone, but they still are managed in the same way as a person with chronic urinary retention. So the person, we say it's a 60-year-old male just to make you get the idea that the likely cause of the retention is BPH, but we're aware that there are other things that can cause the bladder outlet obstruction or retention. So what is the way you would treat this patient who presents like that at that time? How do you manage this patient?
So your management consists of a complete history and examination. All
right. So guess what? Who is talking now?
Can you hear me?
Joel, it's great to take a complete history and examination, but I put it to you, have you ever seen a patient in urinary retention, acute urinary retention?
No, Doc, I've never seen a patient.
They're in a lot of pain. Okay.
Yes, Doc. I was just following a format. I'm pretty sure you realize.
I know, and you can say that, but guess what? As much as you can say that you want to take a brief history and exam because these patients are usually in pain and time is of the essence of managing them, right? What is probably the one most important thing you need to exclude before you ever put a catheter in a patient?
Transection of the urethra.
Right, urethral injury. And how is this? How do you know that someone has urethral injury?
I mean, there could. Well, actually says blood at the meatus. That's true. But
yes, so blood at the meatus is a sign.
There could be clear deformity, a high riding prostate.
Right. So blood at the meatus, perineal ecchymosis or hematoma, and a high riding prostate. Okay. So if you see those, then you want to know. And obviously, the patient would give you the history of a fall-astride injury or trauma to the urethra or the penis, right? But those are one of the two. Those are some of the three most important signs to look for urethral injury. That being said, how do you quickly treat someone in urinary retention?
You have to catheterize them immediately.
Right. And what kind of catheter you're going to insert?
I'd go with the standards. Well, one down from the. I mean, as in terms of the type of catheter or size of catheter?
Yes. And size, the question is, as I said, what type of catheter? It's not a trick question, right? Somebody's typing in the chat a double lumen, meaning a two-way, not double lumen. A two-way Foley catheter, Ashley? Yes. Anna K says an 18 French catheter. Yes, so that's what I mean. So don't allow the examiner to ask you, say, this person is in acute urinary retention, whereas I'd like to take a very brief history to exclude urethral injury And to quickly determine the likely cause of it, I can say that, bearing in mind his age, he's 65, you said on clinical exam we had an enlarged prostate. The likely cause of urinary retention is BPH, and the treatment is urgent urethral catheterization. And I would like to insert a 16 or 18 French two-way Foley catheter. That way it doesn't leave questions for the examiner. All right? So I'm going to put it to you that you try to insert a 16 French catheter and it's just not going. It goes almost all the way up, but it buckles. What do you do at that time?
At that time, so after that, you try one up from a size up to try push.
It does not go in.
Pardon me?
It doesn't go in either.
So then you move a size down.
It doesn't go in either.
Well then, at that point, I think.
What do you think is causing the obstruction?
I'm not sure.
In terms of anatomy. So somebody may ask in the exam, tell me about the parts of the urethra, you know.
Okay, well, you have the prostatic urethra, so I want to say that probably the prostate is causing those.
The prostate, yeah. So some Charlia says the median lobe of the prostate, but it could also be the lateral lobes of the prostate as well. They're growing in, so it's causing sticking together almost. That the lobes are pushing in and sticking together. So it doesn't always have to be the median lobe. It could also be the lateral lobes. But essentially, if somebody asks you to tell them the parts of the urethra, you can say the urethra has two parts, an anterior and posterior urethra. And you can choose to start with the posterior in an anatomical fashion, the bladder neck, the prostatic urethra, the membranous urethra, and that makes up the posterior urethra. And then the anterior urethra, which is your bulbar urethra, and then your penile urethra, the so-called spongy urethra. All right? But if you try and put the catheter up and it goes all the way, but it buckles, then most likely what you have is obstruction at the level of the prostate. If, however, you try and put the catheter up and it stops at about the level midway of the catheter, what you most likely have is obstruction, say, at the bulbar urethra. You know, that's a different etiology, say like a striction. Okay? So if it feels like it's going almost all the way up, but it doesn't go in, that means you're at the prostate. But if it's like halfway, it means it's somewhere at the bulbar urethra. Okay? All right, so 2 sizes up doesn't go in, 2 sizes down doesn't go in. What do you do at that time?
So at that time, you're going to need surgical intervention, so you contact urology. But
that's why we have the coude tip catheter, because if you believe this is due to an enlarged prostate, here is where the coude tip catheter can be used to try and see if that will allow us to get the catheter in. But if that doesn't work, yeah, I agree, call urology, but you're on urology now. So what will we do at that time? Yes, a non-urological person can put in a coude tip catheter, and no, Paige, we do not dilate the urethra, no.
Doc, we go suprapubic.
A suprapubic catheter is one option. We can also do a flexible cystoscopy, but so let me just point out that dilation is the wrong answer. What are you dilating? Dilating the prostatic urethra? No. And dilating a urethra that you don't have any anatomy on? No. So here you have someone who likely has prostatic obstruction, which is preventing you from inserting a catheter. You've tried sizes up, sizes lower. You tried coude tip catheter. Another option you could try is also a silicone tip catheter, right? And the silicone tip catheter is stiffer. And so, 1 second, guys. Give me a 1 minute, please. Sorry about that, guys. Right. So you try it 2 sizes up, it doesn't work. 2 sizes down, it doesn't work. And you try the Coude tip, it doesn't work. The possibility is if you have a silicone catheter, that's a clear one, that's rigid, it does help you to, if so to speak, if the median lobe is enlarged, well, if it's a big median lobe, sometimes that silicone catheter, because it has a little bit more stiffness than the latex, you can get the catheter in, or where you have the 2 lateral lobes meeting, it can bypass it. It can almost push the lobes apart. But if that doesn't work, one of the things urologists may do is put a flexible scope in and get into the bladder. You put a wire in the bladder, take the scope out, and you can put a catheter over that wire. And there are catheters that are made with little openings at the tip of it called council tip catheters. Most times you can't find them, so you can make that little opening yourself, like with a little needle, and allow the catheter to slide over the wire. Because the last resort for us is something surgical like a suprapubic. But going straight to a suprapubic is not a wrong answer either. All right, Dene had a question? Dene?
No, Doc had answered the question.
Okay, right. So that's a sequence of it. But difficult catheterization is a bread and butter common question in the exam. Your options are catheter size above or below, Coude tip catheter if you believe the obstruction is at the prostate. Now, if you think it's within the bulbar, the penile urethra, then Coude is not gonna work, right? Silicone catheter you can try, especially if you believe the obstruction is at the prostate. Call urology, and what we may do is either flexible cystoscopy, put a wire in and a catheter over that, or a suprapubic catheter. All right?
Sorry.
So go ahead, Joel.
I'd raise my hand, but I really can't find the feature. I'm sorry.
Okay, no, that's fine.
Yeah. Could you remind me what you said? It was a flexible scope that you.
Yeah, you can put a flexible cystoscope in. It goes in through the urethra into the bladder. Then through the scope, you can thread a wire. You pull the scope out, and then you thread the catheter over the wire.
Okay.
All right. So you railroad it over.
Yeah, thank you.
Now, so you put that catheter in and you get back 600 mils of cloudy urine. What do? So it's whether the catheterization is difficult or not. Rachel is asking about increasing lubrication at the beginning. Lubrication should always be increased during catheterization. We don't just lubricate the catheter itself. We tend to lubricate the urethra. So we squirt the gel down, we take out the piston out of the syringe, we squirt the KY gel in the center, and then we squirt that in the urethra. So the urethra is lubricated. And the reason for doing that is sometimes when you just put the gel just on the tip of the catheter, it may fall off before you get the catheter in. So you want to lubricate the urethra completely. All right? So you get 600 mils of cloudy urine. What do? So yes, Kanake, it's a Saldinger technique where you put the wire in and you catheterize over. All right? What do you do if you get this 600 mils of cloudy urine at that time? Anybody? No, why would you irrigate cloudy urine in the bladder? What does cloudy urine suggest to you?
It suggests that there's an infection.
Correct. So if you think there's an infection, you get that urine. I see a lot of people saying urine microscopy and culture. Exactly. So you take off some of that urine and you send it for microscopy and culture, but you know very well that you may not get back those results for another 2 to 3 days. So what do you do at that time?
Imperial antibiotics?
Empiric antibiotics. Yes. And what would your choice of antibiotic be?
Augmentin?
Ceftriaxone. So we normally do a second or third generation cephalosporin because we want it to be something that can cover gram negatives, which are the most common cause, and also something that can cover enterococcus. So something like a third or second generation cephalosporin tends to be good. back in the day, people used to talk about using ampicillin and gentamicin, but I can't tell you when last I've seen ampicillin. And we are very cautious about gentamicin in urology because it does have some amount of nephrotoxicity. So we prefer things like second or third generation cephalosporins. Okay? So in that case, you look at the nature of the urine that comes out. So every time you catheterize someone, you should measure the volume. You should describe the nature of the urine, whether it's cloudy or whether it's bloody. Ideally, of course, you would have had the patient's vitals there. So if the patient has signs of an infection, they're febrile, their white cell count is high, the urine is cloudy, definitely they need to be admitted and started on second or third generation cephalosporins. But which other patients with urinary retention must be admitted? Because it's not all who need to be admitted. Who else should be admitted? Tell me, who else do you think should be admitted?
If they have chronic urinary retention.
Excellent. So anybody, right. So anybody with chronic urinary retention should be admitted. And the reason for this is that there is a risk of post-obstructive diuresis, where they start passing over 200 mils of urine per hour for a minimum of 2 to 3 hours. So yes, anyone with chronic retention should be admitted. Excellent. Who else? Who else would you admit? Do we know? So far we have said urosepsis. So somebody in shock, that would be someone in septic shock. I'm assuming you mean Ashley, yeah? Anybody with urosepsis or sign of an infection? Anyone with
if they have a solitary kidney?
If they have a solitary kidney, I would say so, yes, because you're treating them with hands and gloves. What is post-urinary diathesis? What does that mean? Post-obstructive diuresis, Paige, sorry. Post-obstructive diuresis is a concept that occurs when the person has obstruction, whether the obstruction is infravesical, that means at the bladder neck, or whether the obstruction is supravesical, that would be somewhere at the ureters or the pelvises of the kidneys bilaterally. They are at risk of post-obstructive diuresis, which is where when the catheter is passed, in the case of the person with bladder outlet obstruction, or if it is supravesical obstruction where nephrostomy tubes are placed, they start putting out over 200 mils of urine per hour. And we already know what the normal urine output should be for a 70-kilogram man, right? What should it be?
About 70 mils per hour.
Yeah, maximum. So if the person it should be 35 to 70 mils per hour. And this man is passing 200 mils per hour. He's dumping out a lot of urine. And it can occur in chronic obstruction, chronic retention, because of a variety of reasons. One of which is that they have not been emptying very well for a period of time. So now they start to essentially have an asthmatic diuresis. Lots of waste substances that should have been filtered before were not being filtered because they weren't emptying. And so now, again, they have an asthmatic diuresis. Sodium builds up when there is poor emptying. So if they have chronic retention, they're storing a lot of urine in the bladder, they're storing a lot in the kidneys and the ureter because they have hydronephrosis, hydroureter. There's an increased preload on the heart, which increases release of atrial natriuretic peptide. This results now in natriuresis when the obstruction is relieved. And so the natriuresis, when there's sodium being dumped or filtered out, if you will, I shouldn't say dumped. So when sodium is now being filtered at high volumes, water goes with it. So there's not only an osmotic diuresis because of no release of the urine that they had not been passing or highly active molecules, the waste substances, but also natriuresis occurs. And the other thing that may occur is that ADH does not work very well at the time because the prolonged obstruction causes ischemia in the kidney in specific areas, especially where your ADH receptors are. And so the person may have diuresis as well. These are all concepts that can occur in persons with chronic retention, not acute, and therefore you want to admit them and monitor closely their urine output every hour sometimes you have to be doing electrolytes every 4 hours and you're replacing them. Otherwise, they may go into hypovolemic shock, right? I mean, I saw a patient once who had post-obstructive diuresis to the point where he passed 25 liters of urine overnight. So it's not something that can't occur, right? So we have to watch those people carefully. So sepsis is one indication for admission, solitary kidney, persons who obviously have renal impairment, chronic retention, we said, or if post-obstruction, they develop a lot of bleeding, you just want to monitor them at that time, okay? And maybe after you've relieved the retention, yes, Sashana, it is over 200 mils per hour for a minimum of 2 hours. If you have someone who's having heavy hematuria post relief of retention, so they're having a decompression bleed, yes, you can do irrigation, bladder irrigation. All right, so know the patient who comes in with retention, know the instruments we use, like the catheters, the different kind of catheters, their parts, and know the difficult catheterization, how to proceed. Know how to proceed with the person in terms of who needs to be admitted or not. So if the person has no complications, say this man, you get the catheter in, you get 600 mils of clear urine, you do his UNEs, they're normal, you do his CPC, it's normal. What would you do for this man? Because he doesn't need to be admitted. What would you do next? Anybody?
Doctor, we need to probably follow him up in clinic because we need to find a cause for why he had that obstruction.
So remember, we assume it's because of his age. He's 65. 60% of men that age will have an enlarged prostate. You have felt the prostate, it feels enlarged. So I agree, you follow him up, but when? When do you follow him up? Or what do you do for him?
Do we want to do a PSA or just screen him for?
No, so we would not want to do a PSA so early after having urinary retention and catheterization, because we know very well that there are certain things that can cause PSA to be elevated artifactually. One of which is urinary retention, the other is urethral instrumentation. So we'd prefer to do his PSA 3 weeks after, but the point is, if this man has BPH and has had urinary retention, is he gonna have the catheter for the rest of his life?
Well, what we could do is just to check to see whether or not he had a prescription for tamsulosin. I'm not sure if that's if I'm pronouncing it well.
Tamsulosin.
Tamsulosin, sorry. And
so you want to give him a prescription for tamsulosin, right?
Yes.
No. You want to give him a prescription for tamsulosin?
No, just if it's BPH, doc, we want to
yes. So yes, I want to give him a prescription for tamsulosin, and that's the appropriate thing to do. So someone who comes into the emergency room or to you in your office who has urinary retention secondary to BPH, you start him on a prescription for any alpha blocker. The most commonly prescribed one is tamsulosin, but there's also silodosin. And within 3 to 5 days, you can give him an option to pass urine. So you can give him what is called a trial without the catheter, because the drug works that quickly within 3 to 5 days. So you say, okay, sir, you don't need to be admitted because there is no complication here. No sepsis, no renal impairment, no hematuria. I'm going to send you home with a prescription for tamsulosin, and you'll be seeing the urology clinic in the next 3 to 5 days. And on that date, the urologist will remove the catheter and see if you can pass urine. If you can pass urine, you will stay on the medication. If you cannot pass urine, then obviously some surgical intervention will have to be sought. But are there any additional investigations we like to do in these BPH patients?
Doc, would you want to do a KUB ultrasound?
Excellent, yeah. Why would you want to do that?
Because as you said, complications that might arise would be like the hydrourethra and the hydronephrosis, so you would want to see if there's any changes to the anatomical properties.
Yeah, so I agree. I would, first of all, I want to know the size of the prostate, because that will determine the best drug for the patient long term. Tamsulosin is an excellent drug. It's a smooth muscle relaxant. It improves urinary flow rate. But if the prostate is greater than 30 mils, a combination of a 5-alpha reductase inhibitor like finasteride or dutasteride is best with tamsulosin to improve the flow. And I would start that if I get the ultrasound saying the prostate volume is greater than 30 mils, and also I have a PSA that is within normal range. So the ultrasound helps to guide the treatment, the medical treatment. It also tells me if there are any complications. So you rightly said hydronephrosis, hydrourethra, or even things like stones in the bladder. So all of those things are important to take note of. Okay? So an ultrasound is a bread and butter test. Now, if the radiologist doesn't want to do it overnight because the emergency room is busy, you can opt for the patient doing it as an outpatient. But in the emergency room, definitely always do their complete blood count, their urine microscopy, and their CBC. All right, because if the white cell is high, if the urine microscopy is suggestive of infection, if the UNEs are deranged, that patient needs to be admitted. All right. So yes, an ultrasound. And as I said, the PSA 3 weeks or 4 weeks after, when you expect the rise in the PSA due to retention and instrumentation would go down. But what if this patient had chronic urinary retention? You admitted them, they didn't have post-obstructive diuresis. You have decided to send them home. What are you going to do for this patient with chronic retention? How do we treat these patients? Chronic retention secondary to BPH.
Okay, I'm sorry, doc. What did you say the other medication was that you would give it with the tamsulosin?
The 5-alpha reductase inhibitors such as finasteride or dutasteride.
Thank you.
So it's called combination therapy. You combine the tamsulosin, which is alpha blocker, with the 5-alpha reductase inhibitor, like dutasteride or finasteride. All right. So how do we treat the patient? Go ahead.
You wouldn't start the finasteride with the tamsulosin in acute urinary retention?
No, because remember, the reason we don't is finasteride can interfere with the reading of your PSA. Once you start taking it, it can make the PSA go down. So what we like to do is establish a baseline PSA. And that PSA, you'd only be getting it 3 weeks after the retention episode because we know it may be high. So once we get the PSA back 3-4 weeks later, it's normal, then you can start the finasteride or the dutasteride at that time. Because if you start it before, you may be a little confused.
Okay, all right, thank you.
So chronic retention patients need surgery. There are certain people with BPH who should have surgery. We just spoke about the ones who can be managed with medical therapy. Those are the uncomplicated patients with acute retention or the uncomplicated BPH patient. But some BPH patients will need surgery. So if you sit in the clinic and a man with BPH comes in with bladder stones, he needs surgery. Those stones need to come out, and those stones are forming because of his BPH. If you sit in the clinic and a man with BPH has renal impairment, it needs to be managed with surgery. If he has hydronephrosis or hydrourethra, surgery. If he fails medical management, so if this patient had come in saying that he had been taking medication for his prostate, yet he goes into retention, then he has failed the medical therapy. He needs surgery. If the person is on medical therapy for their BPH, but they're having persistent side effects of the medication. So the alpha blockers can cause nasal stuffiness, can cause dizziness. The 5-alpha reductase inhibitors can cause erectile dysfunction, or retrograde or anejaculation, lack of libido. And the patient says, listen, these side effects are bothersome, I do not want them, then surgery may be the option for them. All right? And I'm not going to go into all of the realm of treatments for BPH now. There are many, and the treatment really depends on the resources available. But sufficing to say, the transurethral resection of the prostate or TURP is a gold standard. It can be done with either monopolar or bipolar electrocautery. And it's usually done if the prostate volume is less than 80 grams, which is why you need to get an ultrasound to assess size. If the prostate volume is greater than 80 grams, you can opt for something like a laser a green light laser resection of the prostate. You can opt for a holmium laser enucleation of the prostate. You can opt for minimal invasive techniques that can be done in an office setting, something that is called a urolift, where certain fibers are placed from one capsule of the prostate to the other to retract the prostatic lobes, the lateral lobes. You can opt for something like water vapor thermal therapy of the prostate, the so-called resume, or aqua ablation of the prostate. These latter ones I mentioned are minimal invasive options you can do in an office setting under local anesthetic, and they have durable results. But yes, the TERP is still the gold standard. You can use electrocautery, bipolar, monopolar, but you have newer options that are minimal invasive. In the old days, we used to tell if the prostate is greater than 100 grams, you need to have something called an open prostatectomy. But now with laser, you can do laser enucleation or green light laser resection of the prostate without having to do an open procedure. So the morbidity is less and hospitalization time is less. All right. Are there any questions on the B page patient?
Yes, doc.
Yes.
You said you would only do the TERP if the size of the prostate is less than 80 grams?
Correct. That's what the guidelines say. Some people may push it to 100, but the guidelines say if it is less than 80 grams. In excess of that, you want to do something like a laser enucleation or a laser resection.
I also have a question.
Sure, Shoshana.
In the management of the patient with acute urinary retention, I kind of joined it, but I just want to know, right? After you put in the catheter and that urine is passed, the patient no longer feels pain? Or should we consider
correct?
pain
No,
management?
pain goes away immediately. They will thank you for it.
Okay.
So which is why I've heard in the exam students say give analgesics, but the truth is no analgesic is gonna work until you put that catheter in. So you really not just need to decompress the bladder. The aims of treatment are pain relief through decompression of the bladder. Now it's not wrong to say give analgesics, but the real analgesic will be decompression. Decompression of the bladder, empiric antibiotics, and attention to fluid resuscitation, especially a person who has chronic retention.
Okay. Thank you so much.
Yes, Ashley?
Hi, doc. My question is, so when we put in a catheter and the patient has already drained about 1 liter, when do we now begin to start worrying about fluid resuscitation in this patient?
Well, once it exceeds a liter, so the first thing is you have your retention volume. So you put that catheter in and you drain everything there and you chart it. If it's greater than a liter, you know the person has chronic retention. Then thereafter, you start to monitor how much is coming out every hour. So you get that first volume, that is the start volume, and then you start monitoring every hour. If for every hour after, the volumes are now greater than 200 mils, then you know that you have post-obstructive diuresis, and you start to resuscitate them. Now, what we generally recommend you do is you give 2/3 of whatever was passed in the previous hour. For example, if the last 2 hours you pass 300 mils each hour, then the next hour you're gonna give them 200 mils. So you're giving them 2/3, because if you give them 300 mils back, you're gonna have a vicious cycle where you keep on giving and they keep on passing. So it's once you've got that retention volume, and then thereafter you start monitoring the output every hour, you know what they if they have post-obstructive diuresis or not.
Smell on it now. Go put it back.
Okay, so that initial 1 liter, we're not worrying about that and deferring
No,
the flow?
no, right.
Okay. All right, thank you.
All right. Is everybody clear on that? Because these are questions that must come up in the exam. It will always come in the ASCII section because you have the catheters there, right? So you have to be clear on B page and acute urinary retention and catheterization.
Doc, I'm not so clear on it. So after the 1 liter is passed, we don't classify it as diuresis until they started passing 200 ml per mil for 2 hours?
Correct, because the amount of urine you get out initially is called a retention volume, correct? It's what is in the bladder, right? So you're emptying what is in the bladder, and whatever you empty from the bladder, that will be considered a retention volume. We know usually in acute retention, that retention volume is less than 1,000, and in chronic it's greater than 1,000. So after you put the catheter in, you drain out everything in your kidney dish, you measure, you get the volume there, and you now stick on that urine bag. Everything that starts coming after now is monitored. And that's when you now know if it's post-obstructive diuresis or not, because you have removed everything out of the bladder. So now they start passing urine like normal. So now you want to know, are they in diuresis or not?
Okay, so having decided that they're in diuresis after you notice it 200 ml per hour for 2 hours, in terms of resuscitation, it is after that 200 ml amount that we start giving back 2/3 of whatever comes in the next hour.
Correct.
Okay.
So if you see, remember the definition of retention is of diuresis is over 200 mils of urine per hour for every hour. Sorry, over 200 mils of urine per hour for at least 2 hours. So you monitor and see what is happening in the every 2 hours, the next 2 hours, and after that, then you say, okay, this is post-obstructive diuresis. Let me know. Go ahead and start to resuscitate them. All right.
Thank you.
Okay. Okay. Any other questions on this?
Yes, Doc. What is the role of intermittent catheterization or self-catheterization in these patients?
There's none. If somebody comes in urinary retention, they need a catheter. Whether they like it or not, you're going to tell them what the right thing is. They need a catheter. So you put that catheter in and you leave it until it is best to be removed. Now, if the person has chronic retention, the catheter has to remain there until the issue is solved. If the issue is due to BPH, it's simple. You plan for surgery. So the catheter remains until the surgery is done. If the chronic retention is due to other reasons like a neurogenic bladder, then at that time, you can do intermittent catheterization. If the person has acute urinary retention, you put the catheter in, you start them on alpha blockers if the cause is due to BPH, and then within the 5 days, as I said, you give them a trial without catheter. But you don't do intermittent catheterization for a BPH patient with acute retention. You just wait until the medication starts working and you take the catheter out and see if they'll void. If they don't void, catheter goes back in, you plan for surgery. If they void, they stay on medication. So intermittent catheterization is only in people who have retention as a result of a neurogenic bladder, so to speak, but not the BPH patient.
Okay, thank you, Doc. So you said if they void, that they can just stay on the medication without needing to go
for
to
life.
surgery?
Yeah, for life. And there are lots of patients like that who are on it for life.
Okay. Thank you, Doc.
Right. All right. Any more questions about the BPH patient?
Yes, Doc.
Uh-huh.
Okay, so you had said for the size of the prostate, if it's greater than 30 mils, the combination of the 5-alpha reductase inhibitor and the alpha blocker?
Correct.
Okay, so and that's only for that case when you see it on the ultrasound?
Yeah.
Okay, all right, thanks.
Doc, for the non-invasive techniques that you would use if the prostate is greater than 100 grams, you were saying hydro.
No, so didn't say that. So hear what? A TURP is a gold standard for BPH management, surgical. It is best if the prostate is less than 80 grams. If the prostate is greater than 80 grams, or maybe even 100 grams, all the options included open prostatectomy. But now you can do options such as laser enucleation, or it's called HOLEP, holmium laser enucleation, or laser resection. There are some minimal invasive options that you can do at the bedside in patients where their prostate volume is between 30 to 80 mils. These are like your aqua ablation, your water vapor thermal ablation, transurethral needle ablation, transurethral microsurgery. You don't need to go into all of these things, guys. This is not what you're going to get asked in the MBBS. You just want to know TURP and there are other minimal invasive options. Okay?
Thank you, Doc.
All right. So let's quickly just go ahead, Anna Kay.
Docs, I just wanted to be clear, the management for acute and chronic urinary retention, is there any difference?
You tell me, Anna Kay, from what I've been saying and repeating.
So I know that the acute patient comes in pain, so you're going to catheterize them, right? And that will relieve their pain. The chronic patient, when you place the catheter, so when you catheterize acute patient, are we monitoring them for post-obstructive diuresis?
Do they generally get post-obstructive diuresis, Anna Kay?
No, Doc?
No, so we don't.
Okay.
So we'll put the catheter in. Remember, acute retention can be due to many causes, by the way. All right, we're talking about the BPH patient here. But if the BPH patient comes in acute retention, you put a catheter in, you do the investigations, as I said, ultrasound, urine microscopy, UNEs, white cell count. If white cell count is normal, if UNEs are normal, urine microscopy doesn't suggest infection, you send them home on an alpha blocker. In 3 to 5 days, you try and see if the catheter can come out. If the person has chronic retention, we do all of those things, but we admit them and we monitor for post-obstructive diuresis. If they have that, then you treat the post-obstructive diuresis. If they don't have it and they're stable, you send them home. And you plan for surgery. Very simple.
Okay, thank you, Doc.
All right. Any another question?
No.
No.
Sorry.
Okay, your hand is off. All right. All right, let's just quickly go through stones since that was one of the remits of this evening's stuff review. So back in the day, we used to have images of intravenous pyelograms on the exams. And it's just not there anymore because we don't do them anymore, okay? IVPs, IVUs are things of the past, they're historic. So stones may come up because someone shows you a non-contrast CT scan. And somebody may show you a CT scan with someone with a stone, and they may ask you, how do you manage this patient? Or rather, let's say, how do you think this patient would present? What do you think? What would you say?
In severe pain, loin to groin.
So the typical person with stones will have loin to groin pain, right? What else? Anything else?
Urinary retention.
Really? Do people with stones tend to have urinary retention? No, they don't.
They might have hematuria.
They may have hematuria. So 90 to 95% of patients with stone will have some degree of hematuria, whether it be gross or microscopic, most times microscopic. All right. So I am going to share the screen with you and I'm going to show you a CT scan, and it's fair game. I mean, anybody can what is this? Let me see if I can share my screen with you. Tell me if you are seeing it, please. Is everyone seeing the screen?
Yes,
Doctor. All right. So this is a CT scan of a patient who had loin to groin pain. Well, first of all, he has a history of stones, a family history of stones, in fact, and he had loin to groin pain, and he was sent to do the CT scan, loin to groin pain and microscopic hematuria. So if someone comes into the emergency room with or without a history of stones, with or without a family history of stones, but they have loin to groin pain, one of the first tests you want to do is a urine microscopy to check for the presence of blood or a dipstick. And if the dipstick is positive for blood ideally you want to image them. So what is the most sensitive test to pick up urinary tract stones? What's the most sensitive test to pick up urinary tract stones? Not an X-ray, no, Crystal, not in 2023. An X-ray cannot pick up stones the way you want. X-rays may show phleboliths and you think it's a stone and it's not a stone. X-rays are not going to show you the 10% of stones that are radiolucent, right? And you may have a phlebolith and you think it's a stone and it's not. Or you may have a calcified lymph node and you think it's a stone and it's not. So it's not an X-ray. No, it's not an ultrasound because it cannot ideally pick up ureteric stones, but a CT, and when we say CT, we mean CT KUB, which is, and you are, yes, Crystal, we are told because that is what we teach, because that's what correct thing is. It's a non-contrast CT or CT, kidney, ureter, bladder. That is the imaging of choice. So even if you're in the emergency room and the radiologist says, I don't have space to do a CT tonight, or we don't have a CT, it doesn't mean that an ultrasound is the best test. The best test is a CT. In fact, if you send a person for ultrasound, the radiologist is going to cover themselves and say, they'll do the test and then they'll say at the end of it, ultrasound cannot adequately evaluate the urinary tract for stones, suggest a CT scan. And now you have allowed the patient to pay, not just for ultrasound, but for CT later. Now, there are patients we do CTs on, but with stones, but that's usually someone who already is known to have stones. Maybe they're being followed up annually to check for stone recurrence, but not somebody who is coming in and you want to evaluate for stones. So let's look at the CT scan. Do you see any abnormality here so far?
Looks clear to me.
All right, looks clear?
Yes,
think
sir.
it's clear? What are you seeing on the scan? What is coming up on the scan so far?
Hyperdense areas.
All right, so you're seeing on the right kidney, and you're seeing on the left kidney. So I'll put it to you that right kidney is dilated. Do you see those so-called hypo or hyperdense areas within the center of the kidney? Do you see that?
Yes, doc.
That's the hydronephrosis. That's caliectasis at least. So compare the right to the left. Do you notice that hazy, darker area in the center? Those are dilated calyces on the right and they're absent on the left. So already you know that something is up. Let me see if I can use my pointer here because do I have a pointer on this? All right, let me use a mouse. Do you see this here? Can you see the mouse?
Yes, Doc.
All right, so I see right here our radial opacity. I'm not sure yet if it's a stone, but let's go down with the image and see what happens as we go down, right? So let's go back up and then go down slowly. So first of all, I see, you can see dilated calyces. And if I go back a little, you're gonna see dilated ureter. You see the ureter there, or the proximal ureter, the pelvis is dilated. Do you see that? Yes or no, guys? Speak to me so I can know.
No, doc.
Doc, I see a difference.
Look at this structure here.
I can't tell what's.
So, doc, how I know is
I wouldn't pick it up.
All right, but now that you're seeing it, you know. All right. So these are the dilated calyces. Look at here. You don't see that there. So the size of the kidney is pretty much the same on either side. The cortices are as thick on both sides, but you notice centrally there's dilation in the calyces. So you'll say there's caliectasis. But as you go down, you're gonna notice beginning of a dilated ureter. All right, this is it here. If you continue to follow it, you see it there. It's wide open here. You don't see that on the other side. Look at this. You see this wide open, widely dilated ureter here. you should not have that.
Yes,
and it's
doc,
going all the
yes.
way down. You see that, right? So if you continue with it, you see it there, the ureter is dilated. The ureter continues to be dilated there. And when somebody may ask you what are the parts of the ureter, this is still the proximal ureter from the pelvic ureter junction to the superior border of the sacroiliac joint. Here's the dilated ureter going down, disappears in the pelvis. This is a bladder down here, but we're expecting to see a stone soon if we didn't see it already. I was just focusing on the ureter, but let me see which cut shows the stone.
Excuse me, doc. So in the exam, it will be moving like this, or someone will manipulate it?
Depends on the examiner might move it for you, or they usually sometimes will leave it on the most important image, right? And then they tell you to comment on it, all right? So you see these calcific densities down here? See this here? Do you see this here?
Yeah.
Right. So that's why we say you can't use X-ray as the standard for looking for stones, because some of these are in the ureter, some of these are not, right? Some of these are phleboliths, but let me show you in the axial view. Let's look at it in the axial view and you'll be able to see it very well, all right? So on the axial view, let me go from the top, slowly going down. Focus on this side, the right side. Again, you see the dilated calyces compared to the other side. Tell me that you can see that. So there's calyceal dilation here. You can see that clearly. Look at this big ureter here compared to the small one on this side. Ureter is nice and big here, small here. Follow this ureter down. It's running on the psoas muscle. So you see how nice and wide it is. And we go down with it. Pointer is right in front of the pointer. Follow the ureter, this dilated ureter. So there's definitely hydroureter, maybe moderate, I would say. Mild to moderate hydroureter. You go all the way down with that ureter here. Look at the cursor. The pointer is right behind it, immediately behind it. And we're looking for a white structure, which should be the stone. Cursor here, cursor behind it. Continue to go down and bam. See the stone? Tell me.
Yes, doc.
All right, so that's
Doc,
your
stone. Doc, please. Whoa. Doc, can you please help us to orient ourselves with this?
All right, so remember CT, guys. Basics of CT. The right and left are flipped over, right? All you need to know is that when you look at the CT, life is about comparison, right? Correct? Mostly. Yes. You notice something is different between the right side and left side. This looks almost, the right side looks opened up like a book, and this is dilated here. So the calyces are dilated here. Now, they may or may not show you that image. They may also show you this, where you see the big dilated ureter here. Or somebody may just put you down to the point where the stone is, which is, and if you go to the GU station and you see something like that, then obviously it must be a stone they're going to talk to you about, right? So you have this big ureteric stone here. And so this man presented with loin to groin pain, microscopic hematuria. He was sent for appropriate imaging, which was a CT KUB. We knew the stone was too big for him to pass out on its own, because there's an option for doing medical expulsive therapy, but that would not have been appropriate for him with this size stone. So he opted, and we gave him the option of, somebody says this is an unfair game, but you know what, guys? If you are around, you're supposed to be able to see these things. So I'm sorry to say it's true. If you were around for the past 3 years in clinical or reading, you would know that the CT KUB is the gold standard, and you have to be able to recognize abnormalities. Nobody's going to ask to scroll through like that, but they're expecting to be able to know a CT KUB is a gold standard. And if they show you a white opacity there, then it's most likely a stone. All right, so you have to know how patients with stones present. You have to know the investigations of choice. The radiological investigation of choice is a CT KUB. There are other investigations you want to do, baseline renal function, obviously, CBC, especially if the person comes to the emergency room, and urine microscopy and analysis, much like the same set of patients we spoke about the last time. If the person comes into you like in an office setting complaining of pain, you can decide how you're going to treat this patient. So this patient had a large ureteric stone. Sometimes we give patients the option of medical expulsive therapy to pass out stones. But this stone was certainly too large to pass out on its own. And usually the stone is greater than a centimeter. The likelihood of success is low with medical expulsive therapy. So we gave him the option of ureteroscopy and lithotripsy, which is surgical therapy of the stone. Ureteroscopy, we put a ureteroscope up the ureter, and laser lithotripsy we use to shatter the stone. Some stones, if they're less than a centimeter, especially if they're in the distal ureter, you can give the patient an option of medical expulsive therapy. And do we know what the medication is for medical expulsive therapy? What's the medication for medical expulsive therapy?
Tamsulosin.
Tamsulosin, an alpha blocker, or silodosin, right? So you can, if the stone is less than 4 millimeters, it has almost a 90% chance of passing on its own. If it is between 4 and 7 millimeters, maybe about 40 to 50%, and it decreases thereafter. So you can give patients options for medical expulsive therapy, provided that they do not have renal impairment, they don't have any sign of sepsis, provided that they don't have a solitary kidney. All right? So if the stone is now in the any part of the ureter, you can offer the patient the option of ureteroscopy and lithotripsy. Yes, Ashley, it's fair that you get a CT scan, because if you've been managing patients, you'll be looking at CT scans. Just like in general surgery, it's fair if you get CT scans. So what were we saying? Medical option is medical expulsive. Surgical option, if the stone is in the ureter, it's ureteroscopy and lithotripsy. If the stone is in the kidney and it's large, like a 2 centimeter stone or greater, you have the option of percutaneous nephrolithotomy. If the stone is in the kidney and it's less than 2 centimeters, you have the option of extracorporeal shockwave lithotripsy. Sometimes stones that are in the kidney that are maybe a centimeter or less, you can use a flexible ureteroscope and go up and do laser lithotripsy, and that's called retrograde intrarenal stone surgery. Is that clear to everybody?
One more time, Doc, please. One more time.
Repeat the options a little slower, please.
All right, I'm gonna go slower. First thing, medical expulsive therapy. Who is a candidate for that? A patient who has a small stone in the ureter only. So small stone in the ureter, medical expulsive therapy with tamsulosin or silodosin, any alpha blocker. By small stone, I mean if it's less than 4 millimeters, there's a likelihood of success of 90%. If it's between 5 to 7 millimeters, success, I would say about 50 to 60% really. And if it is greater than 7 millimeters, the success is less. But you don't offer medical expulsive therapy if the stone is greater than 10 millimeters, or if the person has a solitary kidney, or if they have renal impairment, or if they're septic. Surgical therapy. If the stone is in the ureter, you can use a ureteroscope to advance in the ureter, and you can use laser to shatter the stone. If the stone is in the kidney and it's greater than 2 centimeters, you can do an option, minimal invasive option called percutaneous nephrolithotomy. If the stone is in the kidney or in the pelvis.
You're not going slowly at all for me.
But Carla, this is not something new. I would have taught you guys a lecture on urolithiasis.
And then I'm just like, I can't keep up.
No, but hold on, Carla. This is not new information, you know. This is supposed to be a review session. So are you saying to me, this is something that you've been hearing for the first time? Because every year
it's
I
not
teach
the first time, but I would love to have it in like an organized fashion in my brain. So because I'm putting a lot of things in my brain right now, and I'm making notes of it, but I'm missing.
Let me go slowly. medical expulsive therapy. Medical expulsive therapy. Can I go on? Medical expulsive therapy.
Yes, doc.
Alpha blocker. Indication, stones less than a centimeter. So medical expulsive therapy, stone in the ureter, less than a centimeter. All right? Who is ineligible? Renal impairment, sepsis, solitary kidney. All right? Can I move on for surgery now?
Yes, doc.
Surgical intervention, ureteric stone, ureteroscopy, laser lithotripsy. Surgical intervention, large stone in the kidney, greater than 2 centimeters, or greater than 1 centimeter in the lower pole. Percutaneous nephrolithotomy. Stone in the kidney, less than 2 centimeters, and not very dense, by the way, which the CT will show you. Extracorporeal shockwave lithotripsy. Stone in the kidney, less than 2 centimeters, or maybe even less than 1 centimeter. Retrograde intrarenal stone surgery using a ureteroscope, a flexible ureteroscope, and laser fiber. Reasonable now?
Could you repeat that last one, please, Doc?
Retrograde intrarenal stone surgery. And that's for stones in the kidney that are basically anywhere less than 1 to 2 centimeters. You can use a flexible ureteroscope and shatter that stone. All right. So are we clear, guys? Are we clear?
Yes, doc.
All right. So know how patients with stones present. They present with pain. They present with microscopic or gross hematuria. They may present with nausea and vomiting. And if they are complicated, they may present with a fever. Okay? Know that the imaging of choice is a CT scan, a KUB-CT. Know that all these patients should have renal function test done and CBC at baseline and a urine analysis and culture. Know that some patients can have medical expulsive therapy and others may definitely need surgery. Know that if the patient comes into the emergency room in ureteric colic, you can start them off on analgesics, parenteral analgesics like your non-steroidals, and move on to opioids if that doesn't work. So if someone comes in colicky pain to the emergency room, start them off with some NSAIDs like diclofenac, and you can move up to an opioid. And there are people who will respond and can go home, and you can decide electively if you will give them a medical expulsive therapy or they need surgery. But there are some patients who need to be admitted. And those are, again, just like the patient with BPH and retention, patients with sepsis, patients with renal impairment, patients with a solitary kidney. Pregnant patients all need to be admitted. Patients who have persistent nausea and vomiting. And these patients, so the patients with sepsis, patients with renal impairment, patients with persistent nausea and vomiting, or solitary kidney need to be drained. And how do we drain the kidney? This is our question to you. Somebody, Ramona asked if we can use S12 for proximal ureteric stone. Yes, Ramona. Yes. So a double J stent is what we use to drain the kidney, or if the patient is not fit for anesthesia to get a double J stent, we can ask the interventional nephrologist to insert a nephrostomy tube to drain the kidney. Now, we do not do emergency stone surgery. We don't do emergency as well or emergency retrograde renal stone surgery. We drain the kidney, so you relieve the obstruction. That will alleviate the pain, the nausea, the vomiting, drain the kidney, decompress the kidney in someone with septic, improve renal function if the renal function has been deteriorating. And then electively, you plan for your surgical procedure. But never tell me that there is emergency stone surgery, because it doesn't exist. All right, it's just drainage, that's an emergency, and you plan electively later on. In all patients, eventually, you want to evaluate their risk factor for stone formation. So when they're on their normal diet at home, you're gonna do things like their kidney function test I mentioned before, their calcium, phosphorus, their uric acid. The calcium is high, you're gonna do their PTH, and then there are 24-hour urine collections you can do to check for things like calcium, phosphorus, oxalate, citrate, uric acid, etc. You don't need to go into the details, right? No, you do not need to know the grades of hydronephrosis at this level, Ashley. All right? Then this is not speeding. This is when you're doing a review. It's not a teaching session today. It's a review. There are many other topics that I have not gone through, which I can't go through because it's now 6:45. The point is, this is a review session. So you're going to go and review it. Okay? So it's important to note the patients who need to be admitted. It's simple. Patients who are admitted are always the patients who are septic, who have renal impairment, the patients who have a solitary kidney. And obviously people who are pregnant or who have poor resources in terms of at home, poor family resources. So you may want to keep them to monitor them. You drain the kidney if they have any other conditions we mentioned. You start them on empiric antibiotics if you think they're septic. And then you plan electively for their stone procedure, which I mentioned before. Shoshana wants to know which topics that we need to go through in urology. They're the same ones we've been teaching you over the past 3 years, Shoshana. BPH, urinary retention, urethral stricture disease, stones, prostate cancer, bladder cancer. They're the same ones, all right? All right, any questions so far? Ashley says, God is good, and I agree. Guys, don't freak out, please. You know these things already, and we've been talking about it for a long time. So this is just a review, okay? Any other questions? No? Anybody has a question?
Doc, are we going to review bladder cancer now as well?
No, we can't. It's 7 o'clock. And all you need to know for bladder cancer are risk factors. You need to know how they present. Patients with bladder cancer present with hematuria. And what are the risk factors for bladder cancer? We can't go through everything, guys. Remember, this is a review session. It's not a teaching session. All right?
Risk factors would be like chronic irritation of the bladder. Is
that the first thing you would mention to me? If we're talking about bladder cancer, is that the first thing you would say?
A family history?
No. What is the first thing you would tell me if we're talking about bladder cancer?
I see they're saying smoking.
Yeah, so cigarette smoking. Cigarette smoking is probably #1 risk factor for bladder cancer. And what else? Aniline dyes and occupational exposure. All right? So people who are textile workers, thank you. People who work in the petroleum industry, people who are painters. So basically aniline dyes and cigarette smoking, those are the major risk factors. Yes, there's risk factors for people who have been exposed to radiation, patients with chronic inflammation or irritation, but surely you can't tell me that and not mention cigarette smoking first. Okay, and most common presentation is hematuria. That's the main thing that will come up. But listen, guys, go ahead, Ashley.
Sorry, I just had one question. So when we're talking about the hematuria for bladder cancer, is it gross, painless, terminal hematuria, or gross, painless, total hematuria?
It may be gross, it may be microscopic. It's usually painless. It's not usually terminal. But don't sweat the terminal or the total or the initial. Terminal usually suggests bladder, neck, prostate pathology, but it can be total.
Okay, all right. Thank you so much.
Guys, you just have to do your own review, you know. There's no point in sitting on the whole night just going through all the different topics in urology. I think I went through the most common ones first because I know the scenario in the exam is always the catheter, the urinary retention, the BPH. So those are the things I want you to, if you haven't read it, to go back over. We went through stones in terms of the core things, the presentation, the investigation, and the treatment. The other things you will have to go through quickly on your own. Charlia, I hope I'm pronouncing your name properly.
Hello, good day. So I just had one question about the urinary stones. So you said that if it's in the kidney and if it's less than 2 centimeters and it's not dense, that you could do the extracorporeal shock wave.
Correct.
And you said that if it's between 1 to 2 centimeters, you can do the flexible ureteroscope. So I was just wondering, I guess, when would you do one over the other?
Resources and choice of surgeon.
Okay. Thank you.
Yeah.
Oh, I'm sorry, Doc. I don't think I got the difference in the definition of, the definition for acute and chronic. Sorry to go back. So for acute and chronic urinary retention.
Acute and chronic is pain in the presence of a retention volume greater than a liter.
Okay, thank you, Doc.
All right, guys, go read. But I've told you the topics already. Urinary retention, BPH, catheters, urethral strictures, prostate cancer, bladder cancer. Go and read. All right, just do a quick review on those things. But you are going to get CTs there, so don't say it's not fair game. And it can't be not fair game because anyone who has rotated to urology or done the lectures would have seen the CT scans. So it is fair game. You're going to have the CTs. You're going to see the catheters. BPH will come up and strictures may come up as well. So please read those. Okay. All the best and see you in the exam.
Thank you very much, Doc. This was a really good session.
Thank you very much, Doc. This was very helpful.
Well, and just relax. You know it already. Don't freak out because I'm sensing some panic here. It's okay. All right.
Thank you, Doc.
All right. Have a good evening.
Thank you.
Bye.
Same to you.